Hi, friends from across the globe. I would like to thank and express my gratitude to Dr. Mazen Domoni for inviting me uh, to share my experience on this esteemed platform. so, I'll be sharing one of the cases which I performed a few years back, and where I had to improvise uh, during the process, during the treatment. I had to improvise on the technique and patient positioning, the positioning of the dental operating microscope. Which was not usually performed. Like in routine endodontic or routine retreatment cases, we usually do not follow that kind of improvisation. Let us see how we achieved a successful case in the long run. So, first of all, like uh, it's quite obvious that whenever a file separates in an endodontic canal, it's quite an frustrating experience for all of us, for all the clinicians, and it's the difficulty is on one part how to deal with it, and on the other part how to delegate it to the patients. We are just will be concentrating on the other aspect, like how to clinically manage a particular kind of situation that we are going to follow up in this particular case. So here, whenever a file fractures, the first thing that we should do is the clinical examination. Like at what stage of canal preparation the file separated, uh, what was the size of the file, what was the length of the file, at what depth the file separated, at in which canal the file separated. Now, if we are going to retrieve the file, is the tooth structurally strong enough to withstand that procedure, or what will be the prognosis of the case, and so on. Like what will be the difficulty of the procedure when you are going to retrieval or bypassing or whatever. So all this clinical evaluation has to be done. Second, we have to go for a thorough radiographic diagnosis, a 2D and a 3D diagnosis. Now, there are a lot of evidences regarding management of separated instruments in the canals. So one of the things that evidence suggests that existing periapical infections may complicate the mishap along with the stage at which the file has fractured. So this is one of the important aspects that we need to consider while clinically assessing the situation. Second comes the armamentarium. Yes, without armamentarium, a separated instrument, especially if you are contemplating retrieval, is it not possible. First of all, we need to have a dental operating microscope, and second, we need a lot of few amount of ultrasonic instruments. The third thing is the skill. Obviously, if you have a dental operating microscope, you have to be a master of its application. That is one of the things which is paramount when dealing with, at least when we are trying to retrieve the fragments. It is quite important. So just something about me. I'm Dr. Sourav Banerjee. I'm practicing in a steel city of India, Jamshedpur, which is in the eastern part of the country. And I practice specifically exclusive microendodontics and restorative dentistry. I also have an academy, the Microscope and Endodontic Training Academy, and I train here under the hashtag EndoConcept. So that is one small snapshot from one of my one from my operatory there on the right hand corner. So I would like to start the presentation by paying obeisance to my parents and to all the stalwarts of dentistry who have contributed immensely to this profession and pose it today as it is in the current situation. So evidences, we'll see few evidences related to separated files in endodontic canal. So there is one evidence which say that teeth with preoperative lesions were significantly less likely to heal than teeth without a lesion when separated instrument was retained. So when we are retaining, when you are planning to retain a separated instrument in the canal as such, we have to see that whether there is a pre-existing periapical lesion or not. And the evidence says that if there is a preoperative periapical lesion, the situation may get complicated if you are retaining the segment. Another evidence which say that the healing rate for a retained instrument was significantly lower in the presence of preoperative apical periodontitis. So as we can see in this image, there is no as such periapical lesion evident on the radiograph, but yes, the patient had what do you call apical periodontitis. The tooth was symptomatic. So that reason had compelled us to contemplate a retrieval in this particular case. According to the evidence, that is the thing that they are suggesting, that if there is an periapical periodontitis, like there is influence of the exotoxins, endotoxins of the microbes on the periapical tissues, hence the patient is having apical periodontitis, and it may aggravate if the instrument is retained. So let us see like the etiology of the file separation, like white files separate in an endodontic canal. So there could be a plethora of reasons. The popular ones are the cyclic fatigue, you have torsional failure, you have combination of cyclic fatigue and torsional failure, inappropriate use of the files, skipping the manufacturer guidelines, and skill of the operator. So these are the most popular reasons due to which a file fails. Now let's see this case report. So when we did the treatment, the subject was about 28 years of old, and it was having symptomatic apical periodontitis, and he was in a lot of pain. And when we took the radiograph, what we could see is almost 6 mm long file got separated in one of the mesial canals, and on further evaluation, clinical evaluation, it was seen that it was lodged in the mesiobuccal canal. So the decision for retrieval was summed up as because the patient was having apical periodontitis. And one more thing that was appreciated in this radiograph was the 6 was missing. The 6 was missing, and this 7 number tooth was quite mesially inclined and inclined and encroaching upon the missing space of 6. Now this was initially we didn't think that it is going to pose a lot of challenge. So as we proceeded with the treatment, we came to know that this mesial tilt was creating a lot of problem, and all of the procedures we subsequently did was to manage this tilt. So the challenges. So the challenges was, first of all, 6 mm length, separated instrument was lodged. As we all know that the difficulty of retrieval of segments longer than 5 mm is more. So as the length increases, the difficulty level also goes up. So here what we can see is the mesial tilt of the tooth. So this was almost 30 degrees mesially tilted, which was creating a lot of difficulty, as because in when we do a retrieval procedure or any endodontic procedure under the microscope, it needs the surface, the occlusal table, to be parallel to your mirror. So that was the difficulty here. Since that was 30 degree mesially tilted, we had to improvise on the patient position and the microscope position to make that mesially tilt nullified and able to view that segment in the operating mirror. So this was a small amount of radiographic evaluation also we did. We saw that so much of dentine should be removed here to visualize this coronal end of the instrument for successful retrieval. Now, again, the radiographic planning that we did was here, you can see this amount of dentine was planned to be removed so that we could visualize this coronal end of the file and effectively remove it. Now, this was the case, like when we were viewing it through the microscope, what we see that this was the line of vision and it was going like this, whereas the file was lodged here. So it was quite away. So this was the difficulty. When we are focusing it, we couldn't see any bit of the instrument under the microscope. And here we had to think about improvising the position. Now, this is how improvised. What we did, we extended the neck of the patient and made the patient, first of all, lie on a Tendelberg position. And addition to that, we extended the neck of the patient. So when we extended the neck of the patient, and also what we did, we just moved away the objective of the microscope a bit away from the clinicians. So in that way, what we did, we aligned the microscope as closely as possible in line of viewing the coronal end of the file. So this was the improvisation that was done. And when it comes to the Tendelberg position, I just wish to mention one important thing, that this is one of the procedures which is performed in few medical surgeries. And the difficult part with this like the posture is you cannot allow the subject to be in the position for over 10 minutes. So you have to do a procedure 10 minutes, and then you have to make the patient sit back, allow some 10 or 15 minutes of relaxing, and then again you can operate for some 8 or 10 minutes. So this is one of the things that even added to difficulty in the situation. But our plan worked. The position, the improvisation it did, it really worked. So initial radiographic planning was to remove this much of dentine, to make this coronal end visible, and it really worked. So when we worked with an ultrasonic instrument, in a diamond coated ultrasonic instrument, and we cut on this inner wall, so this is the inner wall of the root canal, so we could make this coronal end of the separated file visible under the microscope. So once it is visible, the rest of the job became quite easy. So we modified one of the ultrasonic instruments to do a procedure that is known as the guttering. So what we did a 180-degree guttering around the inner wall of the instrument to make it free from the canal. So that is the first step. And this step has to be done in a low power and in the presence of either EDTA or silicone oil. So this is one important part. So once we free that, once we do the guttering, the instrument starts a bit shaking inside the canal or moving inside the canal, as because it gets freed from the binding of the canal. So that is one important step in the process of retrieval. The second step is when the instrument becomes free from the inner wall of the canal, what we did, we put a thin, sharp ultrasonic tip along the space that is created by the guttering, that is between the inner wall of the canal and the instrument, and we activate it. So when we activate it, we do this at a relatively high power, so compared to the guttering procedure. So here what we do, we place the instrument, we activate it, and we pull it out. When we activate, we have to activate the ultrasonic instrument at the outer stroke. So when we do that, the instrument dislodges and it jumps up in the canal, and it can easily be retrieved, maybe sometimes even with just irrigation, as you can see. So we have just placed the instrument in this space, and we activated and pulled it up, and the instrument pops out. So this is the acoustic streaming that happens because of the ultrasonic vibration and the impulsion that happens that actually lets the instrument pop up in the canal. So here is a small video like how we do the first the guttering, that is on the inner wall we walk to free the canal, to free the instrument from the canal, and then subsequently how we activate in the presence of either EDTA or silicon oil to let the instrument pop up in the canal. We'll just have a small video here. So what we can see here is we are walking on the inner wall with a modified tip, and we are just trying to free the instrument from the canal wall, just working 180-degree on a semicircular motion there to just free it from the inner wall. So once that is achieved, we have to start the next step. And this is very important that when you are doing the guttering, it has to be in a low power mode and in the presence of it has to be in the dry canal. So you have to see specifically that you are working on the inner wall. So once we have done that, what we are seeing, we have placed a tip there and we have activated in the presence of EDTA or silicon oil, and you can see the instrument has popped up in the canal. Just by simple irrigation, the instrument will just float up and it can be located in the, what do you call, in the chamber. It can be easily located. Now, this is the case that we did. It's about, this is the like just after retrieval, what you can see. This is the intra-chamber pictures, and there after retrieval, though it appears quite amount of dentil has been sacrificed, and this is after post-obturation. But the best part is when we see that in a 12-year follow-up, the case is doing just wonderful. So this is one aspect I need to stress upon here. Whenever we are doing some cases, may it be a bit different from the regular things that you are doing, a bit different from our routine procedures, and we have done something different. So we have to always keep on the follow-ups happening. So follow-ups tells us that how our procedures that we have adopted is actually working, whether it is working or not. Sometimes in the initial stage, like someone may think that so much amount of dentin has been sacrificed, maybe the tooth will not survive. But when we are actually keeping the follow-up, we come to know that no, it is surviving. So it was a male patient, young male patient, so having so good amount of chewing force, and still it is performing. So that gives us a lot of confidence, and in future cases we get confidence from this one, idea from this one. We create our own evidences so that we can manage such kind of cases in future in the same way, and we can expect success. So the most important thing that we have to think is, first thing is, it is best to avoid file separation. So we all already have studied this one, like the popular reasons why the file failure, why your file fails, like there is cyclic fatigue, torsional failure, combination of both, skill, inappropriate use. So go on. So how can you avoid that? So when cyclic failure, the best way to avoid cyclic failure is use a superior metallurgy. So you can use good night eye instruments for just having a better cyclic fatigue resistance, and also using the instrument in a brushing motion. So what I mean to say is, cyclic fatigue is a failure that happens when you keep the file rotating at a same point. It is time dependent and location dependent. So what we have to do is, we have to reduce the amount of time that a file spends inside the canal, at the same time rotating at a single space, location. So what you have to do is, you have to keep on using a brushing motion. So brushing motion, what it does, it keeps on the change, the location around the curvature, it changes on, and that reduces the chances of cyclic fatigue and eventually failure. So this is how we can avoid that. The second is, gaining a straight line axis. So straight line axis will eventually prevent torsional failure, and we should never force a file apically. So torsional failure specifically happens when the file gets locked inside the canal and the two portions of the file or the two ends of the file rotates in opposite direction as because it got locked in the canal. So that is how a torsional failure happens. The best way to avoid torsional failure is creating a straight line axis. As you go down, you should see that the file is engaging only in a particular portion of the canal or zone of the canal, not through the entire length of the canal. If the file engages the entire length of the canal, torsional failure chances increases a lot. Now, combination of cyclic fatigue and torsional failure is like we have to avoid both the things that we have mentioned earlier in the two things. Second, what we can do is we have to always work in a wet canal, never in a dry canal, and straight line axis. And again, the same thing, do not force a file. Inappropriate use, like we should think of never abusing a file. So how should we avoid abusing a file? The thumb rule is you should always check the file whenever you take it out from the canal. You should check the fluids for any deformity or something like that. You should never force a file inside apically. That is the second thing how you can prevent abuse. And finally, you should never let the file work in a dry canal. So that is one more thing that we should always keep in mind so that we don't abuse a file. Now, skipping manufacturer guidelines is a big miss that we usually do. So it is not confusing to remember, like if you're using few systems, we don't have to remember the what you call the RPM and torque for each. It is usually mentioned in the boxes and the packages that are used to pack those files. It is mentioned on the like the RPM and the torque. We have to just follow those instructions by the manufacturer. So that is one important thing that should never be missed. And again, skill of the operator, the learning is the only way. So if you are into like if you want to retrieve a file from a root canal, you have to master the use of dental operating microscope. You have to master the use of the hand, mirror, and eye coordination. You have to master the ultrasonic instruments use. And finally, you should always use a reliable endomotor for steady torque and RPM. You should have a sensitive auto reverse inbuilt in that instrument that will always prevent file failure unduly. So before I end my presentation, I would like to say that you can follow my YouTube channel there under that name. You can follow me on the Facebook page. And if you have any query, you can post there. You can post your queries if you have on that email. And I usually share my cases in social platform with this hashtag EndoConcept. You can follow them. So finally, thank you for having me in this wonderful forum. And I hope I could have delivered some useful tips for you to apply in your clinical practice and make your clinical practice easy. Thank you. Bye-bye from India.